Welcome to Conversations in Tinnitus, a video podcast of the American Tinnitus Association. The American Tinnitus Association is a public charity under Section 501c3 of the Internal Revenue Code, a charity dedicated to research, advocacy, education, and support for people living with tinnitus, including their families. Conversations in Tinnitus video podcasts reflect our mission to amplify the patient voice, showcase evidence-based and promising emerging treatments, and highlight cutting-edge research. All of this is made possible through your generous support. Thank you. Good afternoon and welcome to another American Tinnitus Association live webinar. My name is Patrick Lynch. I'm the CEO for the American Tinnitus Association. And as you know, we are a public charity with one goal in mind, one charitable mission and purpose: pursue the silence of tinnitus. We do this through the funding of research, the providing of patient resources, and public education. Today is an example of what we do together, which is provide education. Our webinar and the topic, Understanding and Managing Sound Hypersensitivity Disorders, is an example of what the ATA strives to do every single day, which is bring us all together to understand the latest, greatest, and most scientifically valid explorations of tinnitus and its treatment. Today, we have an incredible panel hosted by an incredible friend of the ATA and our mission. Dr. Rebecca Lewis will do the honors of introducing the panel and moderating today's discussion. But on behalf of the ATA and all of the people that we support, I wanted to say thank you to the panelists. Thank you to those of you who have logged in. And if you are so moved to support our mission or to support events like today's, you can do so at ata.org/donate. Thank you for your consideration. Thank you for your support. And without further ado, Dr. Lewis, welcome to the stage and thank you for hosting us today.
Thank you so much for that nice introduction. It's really great to be here with the ATA today, and I'm very honored to present and moderate today's session on sound sensitivity disorders. I would like to start welcoming our panelists to the stage so that we can start getting through some of our really interesting questions and start highlighting some resources for everyone. So first, I will bring Dr. Jim Henry up onto the stage here. Hello, Dr. Henry. It's great to see you again. We know you as a renowned research audiologist specializing in tinnitus and sound hypersensitivity disorders with your distinguished career at the National Center for Rehabilitative Auditory Research and the U.S. Department of Veteran Affairs. So your groundbreaking work has led to the development of evidence-based tinnitus management protocols, which are widely used in VA clinics and beyond. And, personally by me as well in clinic, as well as you have an upcoming book on sound hypersensitivity disorders, which reflects your decades of experience in auditory rehabilitation and commitment to improving patient care through research and clinical innovation. So thank you so much for joining us today. We're really excited to have you here.
Thank you.
And next, I'm really excited to welcome a colleague of mine, Dr. Kelly John. She is an audiologist and researcher specializing in auditory perception, hyperacusis, and cochlear implants. She is a professor, an assistant professor at the University of Texas, Dallas, and trained at Vanderbilt University, the University of Washington, and Massachusetts Eye and Ear, where she investigated the neural and perceptual mechanisms underlying hearing disorders. Dr. John's work bridges clinical practice and research, and she also focuses on improving diagnostic and rehabilitation strategies for individuals with hearing loss and sound sensitivity. Thank you so much for joining us today, Dr. John. We're really excited to have you here. And then next, I'm also excited to welcome Dr. Perot. She is an audiologist and researcher specializing in hearing loss, cochlear implants, and sound sensitivity disorders. She is a professor at Augustana College and has conducted critical research on online treatment approaches for tinnitus and hyperacusis. Dr. Perot's work focuses on improving access to auditory rehabilitation and advancing evidence-based strategies for individuals with hearing and sound sensitivity challenges. I'm delighted to have Dr. Perot here today, and we're really excited to learn more about your work as well. Thanks. And then last, but certainly not least, we're really pleased and very fortunate to have David Tawarji join us today. He is a dedicated patient advocate and board member of hyperacusis research, and he brings firsthand experience with pain hyperacusis to his work in awareness and support initiatives. He manages and contributes to multiple online discussion platforms for individuals with hyperacusis and tinnitus. And he also fosters more of a sense of community and also this resource sharing, which is so important. So through his advocacy, David works to advance research, improve patient education, and also connect those affected by sound hypersensitivity disorders with critical support networks. So as you can tell, we have really a powerhouse with us today. This is just such a great panel, and I'm really pleased to have everyone here. Just to kind of kick things off, today's session is really about sound hypersensitivity disorders. Being that we're part of the American Tinnitus Association, we want to kind of lay the groundwork and make sure everyone's on the same page about what we're talking about today and how this relates to tinnitus. So I'll kind of pose the first question, and I might toss it to you, Dr. Henry. I might keep it casual today. Maybe I'll call you Jim. I will pose the first question to you. Could you share with us a little bit more about what are sound hypersensitivity disorders and how they relate to tinnitus?
Thank you for the question, and thank you for the introduction. Yeah, it's the more I've dug into the topic, the more I realized I didn't understand throughout my career. I retired a couple of years ago, and my focus was on tinnitus, but that there was always hyperacusis in the background and misophonia in the background, and these are always conditions that seem to crop up in discussions about tinnitus and in our research about tinnitus. When I retired, I wanted to write a series of books, and one of the books was on sound hypersensitivity disorders. Now, they can be called different things: sound tolerance disorders, you name it. I prefer sound hypersensitivity disorders because that really, to me, describes what they are. It is a hypersensitivity to sound for one reason or another, and we're talking about disorders. We're not just talking about annoyance due to sound. We're talking about an actual disorder that requires intervention. So just in general, there are sound hypersensitivity disorders that affect us physically. They are uncomfortable physically. They are painful. And then there are disorders that are emotionally bothersome. So that would be misophonia and noise sensitivity. So there's actually five in my way of thinking. There's five separate disorders. Two of them are physical discomfort due to sound. That would be loudness hyperacusis and pain hyperacusis. Two of them would be emotional reactions to sound. One would be misophonia, and the other would be noise sensitivity. And then there's phonophobia, which is actually a phobia. It's excessive fear of sound. People wear earplugs all the time. I have loudness hyperacusis. I had phonophobia. I learned what to do about it in a tinnitus retraining therapy seminar back in 1997. So I've been dealing with these issues personally, and then I did just get my book published, so it's actually available now, and it describes all of these disorders, and I got a lot of help from Kelly, who's with us, and David. To get that book written, so it's been a real eye opener for me, and also the only other thing I'll mention is what serious disorders these are. And the more I interact with people, the more I realize these people are really struggling. So I'm glad that the ATA is taking this on as a concern, because there are a lot of similarities between tinnitus and these different disorders, and they're often comorbid. So they're things that need to be addressed often at the same time. So thank you.
Yeah, no, that touches on a lot of great points there, and you also provided a nice outline to, I think, another question that a lot of us have, which are around what are those different types of hyperacusis and kind of how they present. I wonder, especially because we have so many people joining us today who might be experiencing these types of symptoms. I wonder if I could ask you, Kelly, Dr. John, to tell us a little bit more and kind of highlight some of the details about how these different types of hyperacusis might present, and just kind of outline that a little bit more for us.
Yeah, sure. I would love to do that. And before I start, I just want to thank ATA for the invitation to participate in this panel. This is my first event with ATA, and I really enjoyed getting to know everyone and how organized it is too. I like this platform, by the way, too. It's really cool. And so, yeah, I'll kind of go, Dr. Henry provided a really great foundation for beginning to answer this question. And like he said, I read his entire book recently, and I think he did such a great job of describing these 5 different sound hypersensitivity disorders. If you look through the literature, the scientific literature, like what Dr. Henry was just mentioning, you'll see that over the past couple of decades, people have used a lot of different terms and a lot of different ways to describe the different types of hyperacusis. And so what we've really been focusing on over the past couple of years in our lab is really the distinction between the 2 that Dr. Henry pointed out, loudness hyperacusis and pain hyperacusis. So the way that we've been thinking about these 2 conditions largely stems from a really interesting study that we recently did, where we just talked to people who have pain when they hear sounds to try to understand what exactly is this? What does it feel like? And what is the lived experience like of having that condition? Because when you think about the term pain, I think people really can describe it in a variety of different ways. And it's not really clear in the literature what these people actually are feeling when they experience pain in response to sound. And so I really do agree with Dr. Henry's definition. Loudness hyperacusis, we tend to think of it more when sounds are perceived as unbearably loud, when they're seemed normal, when other people are perceiving them as normal. So everyday sounds like, just chattering in the background, a dog barking, these are unbearably loud, almost like the volume control has been turned up. Whereas a pain hyperacusis is more of a physical pain that occurs potentially in the ear, but we're finding that people can have pain in other regions of the head and neck as well in response to sound. And this pain feels more like a burning or a stabbing sensation. So it's not a general discomfort or perceiving things necessarily as unbearably loud, but a real physical sensation that often manifests, like I said, as a burning, a stabbing. And I'm sure David will get a lot more into this when he talks about his personal experience with this condition. And so that's kind of the way we've been differentiating it in our lab.
Yeah, yeah, and it's you've highlighted a lot of really new findings, because I think this is something that I personally didn't know about when I was back in grad school now too many years ago. So it's really important to keep this research going and kind of inform not only patients that this is something that is out there, but also providers, and making sure that they know how this can impact their lives and how patients can present. Yeah, thank you for that that nice kind of summary there. I think it's a great segue actually to hearing more from David and his experience. And that is kind of answering this question around how do some of these disorders impact individuals' daily lives, including social, occupational, and psychological aspects. So we've started to get a little bit of a hint from that, but I think we're really fortunate to have David here with us today. And so I'd love to kind of open up the microphone to him and hear a little bit more about his experience. David?
Thanks very much, Becky. So of Jim's 5 disorders he described, my defining one is pain hyperacusis, although things are too loud as well. I'd like to kind of share my story in detail, because I think it can be helpful to give a case study. Everybody's a little bit different, but the way it's affected me is very similar to how it affects others. It's hard to sugarcoat this. These disorders they basically ruin lives. If you're in the severe category, it leaves people homebound and unable to work, unable to socialize. So in my case, most of my life, I had no ear problems at all. Never thought about noise. Actually loved noise. Used to love going to the Blue Angels Navy show and having the planes zoom by me at probably dangerously loud decibel levels, but nobody thought about that. But then about 10 years ago, I started to notice some odd ear symptoms. I worked in downtown Washington, D.C., spent a lot of time walking to and from work, to and from meetings, along the sidewalks, lots of traffic, constant sirens, but I just tuned it all out, just standard city life. But at some point, it felt like the sirens had been turned up, like they were louder. And I was thinking, did the city somehow turn these sirens up? And they were actually causing me physical ear pain. So I got earplugs, and when I heard a siren coming, I'd put the earplugs in, and that would take care of it. It was fine. I'd take them out again as soon as it was gone. But then it kept getting worse. And the earplugs weren't enough for sirens, and even normal noises, kind of indoor noises, started to hurt. And the feeling is hard to describe. It feels like a knife, being stabbed into my ear or something. It's crazy. So I went to see my primary care physician. He'd never really heard of this before, sent me to an ENT. ENT had never really dealt with it. ENT sent me to a neuro-otologist, which is a specialty of ENTs that focuses on the ears. And so I had a long consultation with the neuro-otologist. I had a bunch of standard audiology tests. Everything came out fairly normal on those. And he essentially diagnosed me as having severe hyperacusis, but said there was no treatment. So I did what everybody does. I dived into the internet and I discovered something called sound therapy, specifically something called TRT, tinnitus retraining therapy. And I was about 2 years in at this point and still pretty mild, but it didn't feel mild. It felt awful. So I wanted to fix it, and TRT sounded promising. So I dived in and did it. It involves ear level sound generators and counseling. In my case, it turned out to be a terrible decision, unfortunately. I got dramatically worse during the course of the TRT treatment. I did it for about 6 months. By the end of the 6 months, even at the lowest level of the sound generators, it hurt my ears, and I had to just stop entirely. And during the course of these 6 months, anytime I got hit by a especially painful sound that was worse than my thresholds, I would get worse permanently. So I kept going down in terms of my tolerance levels. So if I could rewind, I wouldn't do that again. Back when I first discovered that on the internet, there wasn't much in the way of social media and patient support groups, and so it was difficult to get a lot of patient reports. Now there are all kinds of patient online groups, and the consensus with a lot more information out there, a lot more case studies, is that sound therapy is probably something to be very cautious about unless you're mild, especially if you're a pain hyperacusis patient. Extreme caution or maybe completely avoiding it is the way to go. And one of the biggest problems is with sound therapy is again this issue of unpredictable loud noise. If you're not protected against loud noise, you never know when a car is going to lay the horn on 6 feet away from you, and that can just be disastrous for somebody who's very severe. So anyway, this has affected pretty much every aspect of my life. I had to stop working. My job was an office job, but even things in the office, a door slamming, a telephone ringing, somebody's voice who's loud, almost anything could be painful. Crackling of papers, somebody wrinkling a newspaper, silly little sounds that it's hard to imagine how they can possibly be painful, but they are. And it's more than it's important to note that it's not just this one symptom. I'd say it's more of a syndrome. So, this is the American Tinnitus Association. Around 90% of hyperacusis patients also have tinnitus. So most of us have both, and many of us are quite severe. But there are other symptoms too. Some people have fluttering of the eardrum. Some people hear sound in a distorted fashion. Some people have something called oral fullness, which feels like you have a balloon in your ear. And then perhaps worst of all is something called pain in silence, where when there is no sound, you have kind of a burning pain feeling, 24 hours a day. And that's just wretched. And then as far as the tinnitus goes, for a regular tinnitus patient, there are some steps you can do. You can use sound to mask it. You can be active socially to distract yourself. But when you're getting pain from sound, it's hard to do those things. You can't mask. You can't be out in the world distracting yourself. So it's rough. So I can't go to a restaurant. I can't do other normal social things with friends and family. Stupid things like silverware clinking on a plate is incredibly painful. So I have to eat at home. Psychologically, I've been more resilient than a lot of patients. I'm kind of by nature an introvert, so it's been not as difficult for me as others. And the internet is also great because it helps to stay connected. I can't imagine what this would be like prior to the internet. But it's still difficult. I tell people to remember, what it was like during the COVID lockdowns, at the peak of the COVID lockdown, when everybody had to be at home and you couldn't go out and do anything. That's kind of what it's like for me and others, except it's not temporary like COVID was. It's years and years, and it's never gonna change. So I've missed a lot of important events. I've missed graduations for nieces and nephews. I've missed funerals for friends and family. And there are a lot of people in my situation, and as Becky was saying, I manage a number of online patient support groups. We've got thousands of people, and each story is a little bit different. From mine, everybody's got their own path where they ended up, but they're all really heartbreaking.
Yeah, and I think that thank you so much for sharing your story, and I think all of us would agree that it is heartbreaking to hear when you can't connect with your loved ones and you can't do the things that everyone else would like to do with you. And I feel like I've been watching Dr. Perot kind of nod along and kind of see, like, I feel like you have maybe something to kind of contribute to this. Would you want to chime in?
Absolutely. Again, I just am, I feel very privileged to be part of this panel. So thank you again, Rebecca, for inviting me in the ATA. But in response to David, thank you so much for sharing all of that with your story. I agree entirely when I think about this in my work as an audiologist at Augustana, where I have a tinnitus and hyperacusis clinic, and I do see many patients, and that's kind of where I started in my work. And then realizing in working with David, many people like you, it was, wow, there's just a lack of resources and evidence-based treatments and all sorts of things. Yet I still saw my patients were debilitated by this disorder. I agree with Jim. It is a disorder. Right. This is a problem. And we as a field need to continue to do better, because I agree the online materials that this is the story that you shared is just what I hear. It's so often right in the clinic, But also the last year and a half, I've been conducting a clinical trial here in the United States. That's a remote counseling program. And I can describe this later, but let me just say we've now had about 45 participants in this study. So I hear these stories from many people. And it is very true that there's just a lack of, well, let's say, support and medical professionals knowledgeable to get access or to help patients. So again, it comes down to, the devastating nature and the question we had up before. What's the impact on the individual's life? And I think, David, you covered that so well for us, right? The social impairments, the idea that you can't attend these activities that are so meaningful in your life because of this. The physical symptoms, which vary, of course, person to person, but do include pain, and that is a real thing, right? And then others, of course, I've worked with and met many people, of course, that talk about not being able to work, or adolescents not being able to go to school, right? Doing homeschooling and other options because of their disorder, because of hyperacusis. So I, again, see so much of what this, just understanding that story, also understanding each person is different, but the ways that we need to work together to continue to help people. So again, thank you for sharing that, David.
Yeah, thank you. And I'd like to open it up really to anybody here if there are other comments around kind of how this looks in the clinic, how the field is aware of this. We'll talk a little bit about research later, but if there are other kind of thoughts around this experience and just where we're currently at, I'm happy to hear it.
I'll do kind of build off of a couple of things that Anne and David have said, and just provide a little bit more some information that we've kind of noticed in working with these patients from a research perspective. One of the audiology students at University of Texas at Dallas and I did a study where we surveyed audiologists across the United States about the amount of education and training they've received on hyperacusis and sound hypersensitivity disorders. And as Anne was saying, the knowledge and understanding of these conditions amongst healthcare professionals is very limited. And we also looked at how many graduate programs in audiology even offer training in sound hypersensitivity disorders. And I'll have to find the exact number. I don't want to say the wrong number, but it was less than 20% have courses that incorporate these topics. And actually at UT Dallas at the time, we didn't have one. And so I've added that on to our curriculum over the past couple of years. And I think that there's a lot of work to do in terms of educating even clinicians and researchers within our own field, not to mention outside of the field, because this really probably is something that needs more of a multidisciplinary perspective to really get at what is going on from a biological perspective, and how can we best treat patients on an individual level. Another thing that I really wanted to point out that I'm very interested in, David and Anne have brought up all of these really severe ways in which this condition can impact social participation, which, as you can imagine, could impact mental health and all sorts of cascading effects. And something that I hadn't thought of until I worked very closely with individuals with pain hyperacusis in our research lab is that every patient that we've talked to, except for one, says that they avoid exercise and physical activity because of their condition. And then, of course, if you're not leaving the house, that's going to impact your physical activity. And so even from that perspective, there are cascading effects that this can have even on other aspects of physical health, not just the ear and the pain as a result of the sound. But some of our participants talk about, I sit at home all day and I'm developing low back pain. These are very young patients. And so someone who I have background in personal training and those sorts of things. So that was something that really piqued my interest and something I hadn't thought of. And so it really is just this multifaceted these cascading effects on, social, physical, and mental health. So definitely a lot of areas in which we can try to work together to improve quality of life.
Yeah, thank you so much. That's really insightful. And I had not even thought about that, but that makes so much sense. And so I think that's also a perfect segue to one of our next questions, which is really, what are the current treatment options for sound hypersensitivity disorders? This is really in general, there are 5 different kind of flavors as we kind of discussed earlier. Different treatment options that we're generally aware of are sound therapy, counseling, CBT, medical interventions. But I wonder, Dr. Perot, would you mind kind of leading us through maybe some of the current treatment options for sound hypersensitivity disorders?
Absolutely, Rebecca. I'd love to go through that. And when I think about our treatment options for hyperacusis, I do say hyperacusis. I'm in maybe a little bit different, rather than saying sound hypersensitivity in my clinic and research. I tend to refer to these as hyperacusis with like 4 subtypes, but we talked about that before. So again, these options for hyperacusis show positive results for patients. I actually look at like kind of 5 ways, but I'll just say we need more evidence for them. But these are some of the management approaches. And when I work with my patients and also in the study, when I'm educating participants through our, again, remote counseling program, this is kind of the way I start. So I first would talk about counseling. And we think about counseling. There's many different platforms that could be cognitive behavioral therapy. That could be, as David mentioned, tinnitus retraining therapy. But it can also be what I was trained under with Dr. Rich Tyler is hyperacusis activities treatment. So we have some counseling programs already, kind of intended for patients with hyperacusis. These are built usually from tinnitus. So really we are just extending that, but so many of the counseling topics also apply. And those of us as providers in tinnitus and hyperacusis have the expertise to kind of really help using those counseling materials appropriately. And so I'll just say, I think using those, we just don't have really a lot of data to show their effectiveness or, studies about that. But let's just say that's the first that I would be working with is a counseling. And it's ongoing. Most of the time when I'm working with a patient, it's like 3 to 6 months of counseling. And we're seeing each other, at least every few weeks. The other aspect that I would talk about with my patients would be earplugs. And I know this can be controversial, but it is important to talk about what is appropriate situational use of earplugs. When I'm working with a patient with hyperacusis, I am talking about filtered, like musician earplugs, if you will, usually making them custom and also allowing for multiple filters. One of my participants taught me this in the study, and it's been great. So starting with a higher dB filter that attenuates more sound, but again, it knocks the sound down evenly. And then as the individual is able to tolerate more sounds, then we actually move to a smaller filter. But there's many different ways, and the sharing of what, again, good earplug usage or hearing protection and what would not be, good, constant hearing protection in everyday environments can be a short-term solution for a long-term problem. So that'd be the second. Thirdly is what David already mentioned, sound therapy. And I think most of the data here from Craig Formby and other colleagues show really good evidence for using, our sound generators, typically with white noise is what that group had shown in many of their, in their studies. It does work well for, I would say, the loudness and annoyance subtypes of hyperacusis. But as we've seen through David's story, and it's also from survey data, as Zach Williams talks about, the idea that pain hyperacusis, may be made worse by sound generators. So we're still, again, need more evidence to, I think, flesh that out. But but we do see a place for sound therapy. And there's many different ways. It can also be done through using everyday sounds. And that's actually what my study is exploring as well, everyday sounds and using a gradual increase in the sound level So that's a therapy that can be done at home, and using, again, just like everyday sounds. It could be bothersome sounds, but also sounds that we might hear. Relaxation is very important. When I'm working with my patients, I'm teaching them about relaxation, meditation, deep breathing, but the idea that this provides good coping strategies in the moment when there's a bothersome sound exposure. It also helps to lessen our fear, anxiety when we are calm and less stressed. So again, I emphasize and teach relaxation exercises. And the final, I would say, part of this that I teach is medications, and really talking about that. I have learned so much from the participants in my research study. There's a variety of different medications, things for anxiety, depression, sleep. One participant just mentioned ADHD. And as patients are using these medications, they actually find that it helps them also with their hyperacusis, or however you define that. So I think those are the ways I work with my patients in helping. So you can see it's multiple things. And I think that's what we all probably know, is not just one, kind of tool in the tool belt that's going to help, but it's going to be many different. The problem is we don't know yet, which of those. So there can be some trial and error. And of course, as David mentioned, it's frustrating because you often ask medical providers, and if they don't know much about hyperacusis, they can't always provide that detail. But
Right.
I hope that's helpful.
Yeah, no, that's a really great overview. I really appreciate that. I would like to give the chance to maybe Dr. Henry, Dr. John, maybe David, if you have other kind of pieces of information you'd like to kind of contribute to that kind of current treatment approaches. Of course, Anne did an excellent job kind of outlining all of the tools in the tool belt. That's always how we like to think about it as well. And I know that, Anne, you're also developing a new tool in the tool belt, as you kind of alluded to earlier, an online treatment platform. I wonder if there are not other kind of comments around the current treatment options. Maybe we could segue to hearing a little bit more about that, and hearing about how effective some of the online treatment platforms are, and kind of what challenges you've seen along the way with that.
Right. Absolutely. I would be happy to. So yes, we know that there are many online treatment platforms actually for tinnitus, and those have shown great effectiveness. Eldra Bukes has a paper from, I think, 2018, and she reviewed in that paper several online platforms for tinnitus, and they are, showing, again, good effectiveness for reducing tinnitus distress, and also even for things like anxiety and depression. So those remote or online treatment platforms are available. And so in the case of hyperacusis, though, that is less so. Actually, there's very limited, I would say the group in England, Hashir Azad, he has actually published a little, but they don't actually have a control group there in the studies. So we know, though, I would just say, and I think we all agree, this online platforms, they do work, right? This is sharing information as we're doing today. So when I worked to develop this study, this remote counseling platform, I call it Hyperacusis Activities Treatment Online. Knowing that this is it's a platform that does work. I also do a lot of teaching at the college, and I had done remote teaching through COVID. And so use that as, a way to kind of, again, modify what we do in person for therapy, again, for remote work. So I think, again, going back to the question, what is the effectiveness? We, in the study I'm doing, we do have a control condition. So we will have that. Better assess. I'm doing a sound trial and comparing sound generator use to the everyday sounds approach I mentioned before. But it is customized. So each person is different, as we heard from David, right? The stories are different. The ways we can tolerate sound is different one person to the next. Seems to depend on the subtype, but again, we will find out more. So I hope that helps just to explain. I think the remote or online platforms offer flexibility. I have very huge interest in this study right now. I don't know that we'll be able to include everyone, but the idea is you can be home and you can do this work and you don't have to come to a research lab. And for many patients with hyperacusis, they don't want to. We do have some metrics that there's some sound involved and testing, but we've done all of those on a remote platform using apps and things. And I think that has been hugely successful. So.
Wonderful. Yeah, thank you. And yeah, as we heard from David earlier, it can be really challenging to kind of get out into the world and kind of have all of that in unpredictable environment to encounter as you're trying to get that treatment. So an online or remote treatment platform would be really helpful. So we're anxiously awaiting your work, Anne. So thank you so much. I wonder, I'm curious. I know that there are these remote platforms for both treatment, but then there's also more support organizations. The American Tinnitus Association is one of them, but there are also other smaller groups along the way that might be able to kind of assist with patients. I might ask David, could you tell us a little bit more about your role and then also kind of the role that you see organizations and different discussion forums and how they might support patients managing these types of conditions? And generally, I know you've been involved in that work, so I'd be happy to hear more about kind of how you view that. Yeah.
Sure. So first of all, like I said, when I first got this around 10 or 12 years ago, there was almost nothing online. Now there are three big social media platforms that dominate it: Facebook, Reddit, and Discord, and each of them has multiple groups for patients. And I manage several of those. One of mine, we get about 20 or 30 new people every week. And often when people join, they just have a huge sense of relief that they've finally found other patients who understand what they're going through. Because it can be so rare that in your own town or city, there's just nobody and your physicians haven't heard of it. So people are instantly relieved that they're not alone. And then they also get all kinds of good advice on coping and management mechanisms. I've developed endless, different strategies that I use. Kelly was talking about, or maybe it was Anne talking about the lack of exercise issue. So I used to be, exercising all the time. I had to give up most of it. But I do get out and walk 5 miles a day. I'm lucky to live near a very quiet national park where there are no cars. And so I'm able to do that. And that helps keep me sane. And so on these online forums, people get all kinds of tips that can help them deal with it better.
Yeah, that's wonderful. And I think that's part of this, right? When you don't have a lot of guidance that's available from, providers as a whole, which is something that we've highlighted here, that, we need to kind of come together in our communities and provide the tips and tricks that actually do help. And we can actually learn from each other, patients and providers, as we've also heard. So yeah, thank you. I'm glad you're able to get out there and that you live next to that national park. That actually sounds like a really nice walk. So I'm glad that you're able to do that. And I'm kind of curious as well. We might kind of turn to our next kind of area here, because we know that there are a lot of these gaps in care and different barriers to treatment. I might turn it to Dr. Henry. Jim, would you mind kind of telling us about what different gaps in care and barriers to treatment you've seen over the years and that you still feel need to be addressed? This might be a large question, and I might turn it to Kelly afterwards to talk a little bit about the research efforts to address them.
Yeah, so as far as gaps, my writing this book, I really dug through the literature, and on one hand, it was nice to see the work that's being done, but on the other hand, it was a little concerning how there's so little agreement on what the terms are that we should be using and what the definitions are and what the specific conditions are. And so, you know, how do we assess a person who comes in complaining of a sound hypersensitivity disorder? You know, so we first need to know what is the disorder? Is it a disorder? Is it mostly a physical disorder, or is it mostly an emotional disorder? So a lot of it is just figuring things out from the beginning, and what are people experiencing, and what are we actually treating? Are we treating something physical? Are we treating emotions? Are we treating a phobia? So I think we need to at least have consensus on what we're calling these different disorders and how we're defining them. That would be the starting point. People need to be educated, not just patients, people who are experiencing disorders, but clinicians. And like Kelly was saying, you know, we hardly have any training in audiology programs. I mean, it's already bad enough for tinnitus, and it's much worse for these sound hypersensitivity disorders. So we're getting, you know, we're supposedly specialists in the auditory system. You know, that would be audiologists and mostly ENTs, but we don't get the training we need to help these people. So we need education, we need training, we need consensus, and then we need research to look at, you know, how can we properly assess these disorders and do it in a consistent way, and then how should each disorder be treated, and a lot of that is based on what is the underlying mechanism of the specific disorder, and we need to be treating the mechanism and not just some blanket, most people really don't know what to do, and that's unfortunate. So I would just end by saying a lot of research is needed.
Yeah, it's very clear. A lot of research is needed, and it's wonderful to hear you say treat the mechanism. I think that is a really fantastic point of view there. Before I turn it over to Kelly, I wonder, Anne, did you have anything else to kind of add around gaps in care and different barriers to treatment?
Well, I agree entirely with what Dr. Henry reviewed. I think that's really where we are is just, and I think also Dr. John went through that, right? So making sure we work to improve, knowledge and training in the graduate programs in audiology. This is key. I myself am a professor and also working in the clinic. And so I have one of the local universities actually has their students come for training for tinnitus and hyperacusis in my clinic. So I think these are things that we need to continue to do. So yeah, the training is a major problem. I believe also in the direct to patient, kind of connecting with patients with hyperacusis. So that's why I went with the remote counseling option, because I see it as, I think, right, Jim went through this, it's a lack of education. However we do define these things, there is a huge lack of education for both providers and also for patients. And the resources we have out there are just making that at times, not totally, but it can make it more confusing, right? So that was the impetus for, kind of the way I went with this one solution. But I think there are many, and I look forward to seeing how we work to address those things.
Absolutely. Thank you so much. And yeah, it's important to kind of highlight that there are different areas we certainly need to focus on as a field, which is a great segue over to Dr. John. Kelly, I wonder if you could tell us a little bit more about some latest research efforts in understanding different sound hypersensitivity disorders. This might be some of your work, other colleagues' work. What's going on out in the field?
Yeah, thank you for that question. So I want to say that I, again, completely agree with everything that Dr. Pro and Dr. Henry have just said. And a lot of the issues that they have highlighted play very nicely into what I understand people are working on out in the field, and some of the reasons why we really experience the challenges that we do, both clinically and from a research perspective. I want to highlight what Dr. Henry said about really not having a good understanding of the mechanisms of the condition. And that makes it very difficult for us to be able to develop really sensitive tools that we can use clinically to not only diagnose the condition from a more objective perspective, but also monitoring symptoms over time and following interventions. So there, and you actually, Dr. Henry, Dr. Pro, I'm curious if you have the same impression that I have about this, but when I look out to the field and attend conferences and speak with different colleagues who are working on hyperacusis research, I think my impression right now is that it is heavily skewed towards animal models and not so many researchers who are attempting to kind of translate what we know from the basic science animal work to human participants and initiating the types of important clinical studies that like Anne is running right now. And if you, I don't think she specifically mentioned this, but her clinical trial is the only clinical trial for hyperacusis in the United States at this time. And so I think that really highlights kind of the lack of, not lack, but the lesser amount of laboratories that are focusing on the human side of things. We have decades of work in animals from, Dan Polly, Dick Salvi, these sorts of individuals who are studying, what happens in an animal model if you damage the ear and look and see behaviors that are similar to what we might expect an animal to behave like if it had hyperacusis, but really understanding if that is actually happening in people and how to measure it and what to do with that information is really lagging behind. And so I think there is something that we're trying to do is take some of the information that we know from animal studies and develop tools to try to measure some of these effects in humans with a specific interest in trying to understand how the mechanisms might differ depending on the types of symptoms that a person has. And so we are very interested in pain hyperacusis, and I am working with a colleague. We have a Center for Advanced Pain Studies at UT Dallas, and so I've connected with colleagues there to see if we can maybe approach this topic from more of a chronic pain standpoint and see if we can develop tools to quantify pain hyperacusis that are a little bit less traditional. So in audiology labs, we usually like to present sounds and measure responses to those sounds, whether we ask the person to tell us what they hear or measure responses from the brain. And we certainly do some of that work in people who can tolerate it. But we are interested in developing tools that kind of bypass the need to present sound and measure a response so that we can start to understand what's happening in individuals who are not able to participate in that type of assessment. And so that's something we're really interested in, is translating what we know from animal studies to people to see if we can start to understand what's actually happening in humans and how that differs depending on their lived experiences and the types of symptoms that they have. And we also have a few studies in autistic adults. As many of you probably realize, hyperacusis is very common in autism. It seems to be more of a loudness hyperacusis that is a little bit more common, although some of them do tell us that they have pain when they hear sounds. And so that's another subtype that we're looking into with some of these studies. So I think that those are some of the, there's so much, there are so many things we could talk about, but I think for me, that's one of the big questions is how do we, like Dr. Henry said, try to understand what's actually happening so that then we can develop better tools to use clinically and better treatments.
Absolutely. Yeah. And I'll open it up because I know that there's ongoing research. So if Dr. Henry, Dr. Perot, David, anyone has other comments there. I know there is so much. It's a wide world of research, and that's great. And there's definitely different areas that we need to focus on. Thank you also for highlighting the different gaps in the research. I think that there are different areas we need to focus on. It sure sounds like we need more human studies. So thank you, Anne, for starting that work. Yes, please.
Yeah, I was just going to also mention two studies that were published this last year that I think are quite notable. But I do agree, there has been a focus on animal-based research. So there's clearly a need for us as a field to work on, thinking about more translational studies. But these two, one was from Dave Edens, and Craig Formby. And this was published again 2024 in the journal Speech Language Hearing Research. And in that they actually had 4 papers. And what they showed is how they developed a very novel occluding ear mold that's coupled with an ear level device. And this is intended again for people with hyperacusis. And they conducted a clinical trial. They used counseling as well, which I did, talk with them in developing my program, the Hyperacusis Activities Treatment Online. They showed that this was effective in 11 of the 12 participants that they had in the study. So I think we do have some really good studies showing, and different innovations, different solutions for helping patients with hyperacusis. The other, I'm probably not going to say this right, but Theron and colleagues, this is 2024. They published a study, and it was on a novel cognitive sound exposure therapy. They use both short and long-term kind of exposure therapy for hyperacusis. This was done in the lab. And what they also combined was like breathing and relaxation exercises. I had mentioned those previously. And they also use like this, what's called acceptance commitment therapy and cognitive behavioral therapy in their work. And the participants completed 6 sessions as part of the study. They showed an increase in the sound exposure level, decrease in the hyperacusis symptoms, and again, a reduction in just the reactions to hyperacusis. And there were 30 patients in that study. So I think we do have some really good, and those were, again, 2 published studies from last year. So maybe just wanted to highlight those.
Wonderful. Yeah, thank you for highlighting those. I think it's important to make sure we're all aware of the latest and greatest research. And I'm kind of curious. Some of this kind of segues into how we all can better work together. So I might pose a new question here. How can we, as researchers, clinicians, patient advocates, how can we all work together to really collaborate and improve the state of our field? And I think a lot of us have thought about this question over the years. I think, what comes to mind is, David, you probably have a lot of thoughts around this. So I'd be curious kind of to toss it to you if you're interested.
Sure. Actually, I wanted to start and actually quote a sentence from Kelly, because I think it's just a perfect sentence. This is from an article Kelly published recently. She said, I hope you don't mind, Kelly. She said, by virtually interviewing and surveying a group of 32 patients with severe pain hyperacusis, we were able to learn just how life-altering the condition can be. It was eye-opening for us to learn that every single participant felt a lack of empathy and support from healthcare professionals. So every single one, 100%. So I think what would really help a lot is for researchers and clinicians to listen more to patients. We're not animals. We can say what the symptoms are we're feeling. We can say what makes us worse. And whenever we have a chance to respond to a survey, I always encourage people to do that. Kelly, for example, has done a number of surveys recently, and that's such a perfect way for hyperacusis patients to be able to provide input into research, because it's difficult. We're all scattered around the world, and physicians have never really heard of our cases. But when somebody like Kelly puts out an internet survey where everybody can answer it, then it pulls all the information together and gets it out. So that's my advice to patients, and also to researchers. More surveys and get those answers submitted.
Yeah. More work is needed. We all need to provide input. And that's a really great call out. And thank you, Kelly, for doing that work. I wonder what any other thoughts around how we could work together. I know that there are kind of larger center grants. We have kind of different patient support groups that we could, kind of bridge the gap there. There are various kinds of ways that we could work together. But I think the survey is definitely one way to make sure we bring all of those different perspectives together. Any other thoughts around how we could collaborate more effectively?
Well, I have one. I think just this opportunity to come together is really important, right?
Yes.
So the idea that we have a support organization in the ATA, I think that plays a huge role in the success of the treatments and in the lives of patients with hyperacusis, right? I was going to maybe also, comment with what David said about communication and the idea that, that providers listen. I think it's just such a great point that we need to be at a place of listening because we really don't have all the answers, right? And this has really hit home for me in the last year as part of that study that I've been conducting. We do weekly discussion forums. These are usually 45 minutes to an hour. And so in the study, we're building it with cohorts of maybe 10 to 12 people at a time. And the idea is we build a sense of community by sharing on this kind of platform, an online platform. It's a synchronous discussion. And, the participants are able to share their experiences, but then we also, kind of had guided discussion questions and things. And David, I have learned so much just by simply listening. And that has helped me to come up with new ideas, but also respond, again, give education when needed. But other times it's really about, I was the one that needed to be educated to learn more. And then I'll be able to kind of move forward with new ideas and other things. So I think that's a really good point. I think the partnerships are really key. And, and seeing that happen, it will, as we share, these stories together and do this work. But I would just say, I think communicating honestly, about the needs of both the patient to the provider. I just think there is a lot of mistrust in the medical field for people with hyperacusis, and I understand that because there just has not been empathy and also let's say evidence-based treatments even, mentioned or provided, oftentimes misguidance. So, how we advocate is really critical. We need to do that. I agree, more effectively.
Yeah. Thank you both. Yeah, that's really great highlights and very important. I think we can all stand to be better listeners, and especially to our patients because they're coming to us for assistance, and the only way that we'll be able to help is to really understand their concerns. So that's a really great call out. Thank you. And then I might turn it to our last kind of formal question before we open it up to Q&A. We have a really captive audience here today with different attendees who might want to support and engage different research initiatives. So I might open it up to the group. What can we do? What can we do to help? Is there, please, Dr. Henry.
I think what Ann said was really important. What do we do about the fact that clinicians don't understand these conditions, don't provide the proper empathy? I mean, we've all been in the tinnitus world for so long that we know that the common response to the patient complaining of tinnitus is, well, there's really nothing we can do about it. You just need to go home and learn to live with it. And that's just devastating to a patient. And so it's probably an order of magnitude worse in the sound hypersensitivity world, where as little as we know about tinnitus, we know far less about these different sound hypersensitivity disorders. So really, it's all about the patient. And I'm old enough that I go back to the Jack Vernon days, and I actually worked with Jack Vernon, and he used to always say he learned the most about tinnitus from his patients. And I would have to say the same thing. Unless you sit down with a patient and talk to them, you really don't understand the disorder. So that's why it's so good to have David on this webinar because we get the patient perspective. And I think we all need that perspective. And then just one last thing. My dream, my hope before I retired was that I could put together a network of clinics that would conduct research. And there's a real advantage to doing research in clinics because you're using real patients, you're getting real data, and you can apply that data immediately in other clinics. And so I wrote a huge grant to try to do that kind of work, and it just got shot down. And that was, I didn't even resubmit. But I did, after I retired, I've been working with a group that's putting together a tinnitus learning health network. And it's kind of the same idea. And it's basically networking clinics together, all focused on the patients and what are these clinics doing to help the patients. And I really believe in the concept that if we can network clinics, work together, establish consensus, establish agreement, listen to our patients, share what we're learning with each other. And I see that as a potential way forward to address these gaps.
Yeah, absolutely. I think the Tinnitus Learning Health Network, it makes a lot of sense to have people communicate, have a little more open communication. And I think as we've heard, listening to the patient is key, and being able to capture those insights really throughout a different network of clinics sounds like it would be very beneficial. So that's wonderful. Glad that work is going on. Wonderful. Well, as that Tinnitus Learning Health Network is kind of being kind of developed and is underway, I know that different folks are really anxious to contribute. I know that we can point different people to online resources to volunteer as a participant. But I also know that we can support the ATA. So if others can provide any support to the ATA, that would be helpful. You can scan the little QR code in the corner. But I wonder, maybe we'll open it up a little bit more to some of our questions from the audience here. We got some questions a little bit earlier that I might start with. And Anne, I saw that you were kind of ready with some answers. So I might start with you. Let's see. One very specific question is when there's a setback with hyperacusis, what is generally what can be done? Is it something that you need to kind of sit back and take a minute, or how do we address a hyperacusis setback? Any thoughts around that?
Absolutely, yes. We actually just talked about this in our weekly forum in the study. It was there was someone that was asking about this, right? And so I guess what we usually talk about, I reiterate the point of always, maintaining a sense of hope. I think it's hyperacusis, we said, it's debilitating. It is difficult and frustrating when these setbacks occur. One of the participants talked about their audiologist, who is a hyperacusis tinnitus, specialist, said it's often, maybe like 7 steps backwards, 1 step forward, 6 steps backward, 2 steps forward. So those setbacks being, the step backwards. And this is very difficult, hard to maintain hope. On that call, we actually had a clinical psychologist, and I do believe there is a place for, kind of emotional support. And, I think that can be helpful because this is so devastating when these things do happen. But I do believe, the idea is that we stay resilient, recognize the pattern of the, forward and backward, trying new therapies, but also recognizing and trying to learn from I'm going to just say failures for lack of a better term. But when those setbacks do happen, what are things that we can do? And often, the actual patients that were on the call said that often they will have, like, the next day might be a more quiet day. But they also describe this idea that it's almost, if I know I'm going to be in a sound exposure, a loud sound exposure, having the tools, the right, not only hearing protection to avoid a setback, but like one patient also talking about the theater. Where do I sit in the theater? Like, these are not questions I, as someone without hyperacusis, think about, but my patients do. And I think it's really important to, talk through those things and then understand what did we learn from that setback? How can we avoid it, but also not lose hope through that. And I will just say, oftentimes the clinical psychologists or our, counselors, these colleagues are just really helpful in also helping to address some of the emotional burden that happens with the setback.
Yeah, absolutely. I can't help but think of a old friend of mine who said, I think everyone who's born just needs to have a therapist. I think we can all kind of use a little support. So, but yes, that makes a lot of sense. I'm curious also. I know linear is something that we've talked about on this platform before. It's more of it's certainly been advertised as a treatment more for tinnitus and tinnitus management. But are we aware of whether linear is an effective treatment for hyperacusis? Is that part of the indication? Does anybody want to kind of speak to that? And it might be you again. I'm not sure.
Well, I do fit linear at my clinic.
Great.
But again, I'll open it up to others. But I'll just say, in talking with the neuromod representative about this, because I have had a few patients with hyperacusis that have used linear. It is not indicated for that. So linear should not be a treatment for hyperacusis. It really is developed for tinnitus. But I have had patients with, let's just say, a more, kind of milder form of hyperacusis, but the primary reason they're getting linear is for their tinnitus, of course. And I have seen just one recently finish the linear treatment and did well, right? It did better with linear and all the metrics, because I do measure my patients with several different, validated questionnaires related or on tinnitus. So those things were very positive. The treatment outcomes were good, but I've also had one where that was not the case. And I'm sure if you look at, I don't know that there's a lot of published data to answer this question. There are studies from the Conlin papers on linear, and they talk about the side effects of linear. And there were, but I don't recall that I just don't know the number for related to, was that increase in sound, sound sensitivity, or I don't recall that, but there are some published data, again, going back to the clinical trials on linear. But I think that if you ask clinics today, that's a bit mixed. But it is not supposed to be indicated as a treatment really for hyperacusis. I can tell you that.
Yeah, no, that's helpful. I never really considered it a treatment for hyperacusis, but it does make sense that if you have, tinnitus, you want to treat the tinnitus, and you have some hyperacusis in the background that, may or may not be affecting it, then you could try it out. Another tool in the tool belt, and just being cautious that, of course, if things are getting worse, then get in touch with your provider and kind of talk through that. Yeah. And there's other questions around different kind of future interventions. Kelly, I might toss this one to you around, are there any research studies being done around kind of pharmaceutical interventions for hyperacusis? That might be something that's, tested a little bit more often in animal models before it gets to a human model. So I'm curious if you know anything about that.
Yeah, that's a really great question. And I know there are a lot of people who are thinking about that. To my knowledge, we've talked about, there are no clinical trials currently available that are looking at pharmaceutical interventions for hyperacusis. But I will say that in the study that David mentioned that we did, where we interviewed patients with pain hyperacusis, one of the goals of that study was to try to understand what are these individuals trying in order to relieve their pain? And we got a lot of really interesting information about different pharmaceuticals that they have tried or that their providers have prescribed to them to see if they would help. And I think Anne was mentioning this before, a lot of anxiety medications, depression medications, but there were some interesting trends that we are interested in exploring. And one of them is looking at the effects of lidocaine. And so we don't currently have a study available to participate in for that, but that is a question that we're exploring with our colleagues in the Center for Advanced Pain Studies at UT Dallas. So hopefully down the line, us and others will initiate trials that people can sign up for, because I know there is a lot of interest in some hypotheses circulating around. I think someone mentioned clomipramine. I don't usually say it out loud, but so I think that's how you say it. But there is some anecdotal evidence that perhaps patients are finding benefit from that. So I know that an ENT named Michael Boats in Belgium, he will be presenting some information about his experiences with that at the annual Iowa conference for tinnitus and hyperacusis. So if anyone is available to attend that conference, there's a virtual option, and I would recommend doing that, and you can learn kind of what his thoughts and experiences are on that. And so it's definitely, to my understanding, things that researchers are very interested in, and there might be some opportunities in the future to participate in that type of research. Yeah.
Great. Yes. Thank you. Yeah, there's so many opportunities to kind of contribute back to the field. So thank you for highlighting those. I'm wondering, there might be a thought, a concern, a misconception, I'm not sure, but we're kind of wondering about the connection between tinnitus and these sound sensitivity disorders. Does one cause the other? Do they always come together? Does it always go tinnitus leads to hyperacusis? Is it hyperacusis leads to tinnitus? What is this, and how should we think about that? And I might toss it to Jim, if you're willing to take it.
Yeah, that's a good question. So I think it was David who said that 90% of people with hyperacusis, or at least, yeah, either form of hyperacusis, loudness hyperacusis or pain hyperacusis, have tinnitus. And then we know a goodly number of people with tinnitus also have some form of hyperacusis. Now, depending on the definition of hyperacusis, that percentage is going to be all over the map. So, but we do know that the conditions are related. So if a person has increased auditory gain in their central auditory system, like the volume control is turned up, that could make the tinnitus emerge or get louder. And it could also be the reason a person has loudness hyperacusis. If a person has pain hyperacusis, then it's, we think, a different mechanism, and it would not be the same mechanism as loudness hyperacusis. It would be, there's all kinds of reasons why a person can have pain in the ears as a response to sound. So I think depending again on what exactly the disorder is, the treatment needs to be tailored to address that underlying mechanism. I'll stop there. Let anybody else jump in.
You know how wonderful it is to hear treating the mechanism. I think we're all on board with that. Yes.
I appreciate that so much, Dr. Henry, hearing your response there. And I agree, it is so much about the right treatment for, the subtype, for the patient, right? Making sure we get that proper, executed, and having that treatment is so important, because it could potentially, tinnitus, if not managed well, using the wrong, I think of patients who have used various sound therapies in the wrong way. Actually, this has been something recently I've observed, using smartphone apps. One treatment, the patient was listening to their tinnitus with earmuffs. And this was something that was on the internet. And of course, I think those things could lead to a hyperacusis situation when used improperly. So again, I think proper education, the right treatment and guidance, a knowledgeable provider to, to put that plan into place is really key.
Yeah, and I might touch on just one more thing here. You mentioned the knowledgeable provider. So when we think about collaborating with different healthcare professionals and making sure that we have, making sure this patient is receiving proper referrals and things like that, how do we think about the role of primary care, neurology? How do we kind of work together in these kind of this multidisciplinary field? And I know, I think various folks have kind of touched on this. Kelly, I think you did as well. But I know there's a question around neurology specifically and how it kind of relates to this, and potentially why neurologists aren't managing these disorders. Are there any thoughts around kind of the multidisciplinary aspect of this and how we ensure that we keep other related healthcare providers in the loop for these patients? And I might toss it to, I don't know, Kelly or Anne. We're all very polite.
So I'll just share my experience.
Oh, great. Perfect. Thank you.
As a patient, I've actually found my primary care physician the most helpful.
Oh, great.
I've tried countless medical interventions, all sorts of prescription medications. In the groups, everybody tries everything. And my physician has been very willing to, go along with almost any idea. So I've tried all these things. I just want to also say that for a good chunk of us, the pain hyperacusis types, more so than treatments, for a lot of us, the goal is to not get worse, because I think Anne mentioned Zach Williams' paper from Vanderbilt. He said that 28% of pain hyperacusis people got worse from sound therapy. And that's not good.
No.
So for a lot of us, again, the goal, it's not to try to treat it, because there just isn't good treatment, but it's to not get worse.
That's a really good call out, because I think we as clinicians always think, well, we need to bring this person back into a better area of functioning. And if the counseling is really around maintaining your status, that I think it's a really good call out. Yeah. And I'm kind of curious to follow up on that. And I might then open it up to the group. How do you maintain kind of an optimistic mindset? How do you maintain hope? How do you kind of keep trying these different approaches and look to the future? What kind of inspires you, David?
Well, for me, I try to stay involved in. I try to help. Well, in addition to working on the support groups, I try to help raise money to fund research for grants. And it's tough because there's not that many of us, and a lot of people are disabled and have no income. So we get $5 here, $10 there, and eventually we can afford a small grant. But that at least helps give me some hope for the future.
Yeah. Yeah. I think that's what we hear a lot is that the research and really putting our efforts toward research is the way to kind of look toward the future when there's this kind of absence of different options. The support groups are really a wonderful option. And I think if folks aren't taking advantage of that, you can check out the American Tinnitus Association's website. There's different support groups listed there. David, do you know I know that you're on the hyperacusis research board, but is there a specific hyperacusis, support page that you know of, or is it mostly with us, with the American Tinnitus Association?
So actually, there's all kinds of things, but I did want to just mention, so Jim has started a monthly hyperacusis discussion group. It's over Zoom. It's open to everybody. It's the third Thursday of the month. Anybody who's interested in that, they can contact me. My information's on the ATA website, or Jim, contact Jim, his information. but we've been getting sellout crowds. We did a test one in January and February. Each one maxed out at our 100 limit.
Wow.
So I would encourage everybody to participate in that who's interested. And I thank you for doing that. It's been fantastic.
Yeah. Thank you, Jim. And thank you, David. Yeah, that's wonderful. And I see, yes, there's some links being posted in the chat for people to kind of find those additional resources. Well, I think we've taken up a lot more of your time than we expected. So thank you so much to our panelists. I just am delighted to hear all of this latest research and different approaches to managing hyperacusis and sound sensitivity disorders. I will do a quick kind of call out that the ATA is a charitable donation, as we heard from Patrick earlier. And if you have any, kind of capacity or bandwidth to provide some support, you can scan the QR code in the corner. David highlighted that it can be really challenging, and this is one of our few platforms that we get to connect with folks. And so if you found any value from this, please let us know just by scanning that QR code. But again, thank you so much. This was such a wonderful session. There will be more like this in the future on different topics. And so for now, we will say goodbye to our panelists, but we hope to see you again in the future for another session just like this one. Thank you, Dr. Henry, Dr. John, David, and Dr. Perot. We've really enjoyed having you here today.
Thank you. Bye, everyone.
Bye. Thanks so much.
Please consider a donation today.